Hello, everyone. I am Rahul Gosain.
I'm Rohit Gosain.
And we are Oncology Brothers. Though a lot of data was presented at ASCO 2023, as a community medical oncologist, there are a few key studies that we need to get comfortable with. Today, we'll focus on 4 important studies in GI malignancies presented at the annual ASCO 2023 meeting. We'll start off with the PROSPECT trial, followed by 2 studies, norpact 1 and NAPOLI 3 in pancreatic cancer, and then imbrave 050 in adjuvant hepatocellular carcinoma. To walk us through these critical studies, we're joined by Dr. Shaalan Beg from Texas. Dr. Beg, thank you so much for joining us.
Thank you so much for having me.
Dr. Beg, welcome. Let's start off with the first study, PROSPECT trial. Before we dive into the study itself, just to reiterate the current standard of care that has been multidisciplinary approach, mainly involving total neoadjuvant therapy, chemoradiation or chemotherapy, vice versa, followed by surgery, or chemoradiation up front, followed by surgery, and then adjuvant chemotherapy. Radiation here has multiple side effects that patients have to battle in long-term setting. The PROSPECT trial is an attempt to see if in some patients can we successfully avoid neoadjuvant radiation. Diving into this trial further, could you please walk us through the study design?
Yeah, while I talk about study design, let's take a second and understand how we got where we are for rectal cancer. When we look at the large German neoadjuvant rectal cancer study that evaluated chemoradiation surgery followed by chemotherapy for rectal cancer and became our standard of care for decades, it did so by showing a reduction in pelvic recurrence rates and sphincter preservation. So on this trial, they wanted to see how they can systematically exclude radiation for a defined group of people. They took people who had T3N0 rectal cancer who were not candidates who did not require sphincter surgery. So these were higher rectal tumors, not the rectal tumors that would require an APR. And they randomized those folks into getting the conventional pelvic chemoradiation followed by surgery and adjuvant chemo, or upfront chemotherapy and omitting radiation in people who have a good response. So if people started off with chemotherapy, they got 3 months of chemotherapy. If they had more than a 20% response, they went straight to surgery and then adjuvant chemotherapy. But if they didn't have a response, they got radiation like they would have otherwise. And this was a way to really cherry pick a group of patients and say, hey, will we still do fine by omitting radiation in this group of patients in order to avoid both some short-term side effects around the radiation as well as long-term side effects that can take place. And that's what led to this clinical trial that was presented at ASCO this year. When we look at the results, they compared disease-free survival at 5 years. And we see that the disease-free survival for chemoradiation, which is the way, quote unquote, we've always been doing it, so the disease-free survival was 78% with chemoradiation. When we deploy upfront chemotherapy followed by radiation in just the non-responders, we don't see a reduction in disease-free survival. This was a non-inferiority clinical trial, and you can see, the overlapping Kaplan-Meier curves. I was really impressed with the median follow-up that they've had of 58 months as well for the study, which tells us this is a fairly mature result. And, we've already been starting to receive questions from patient advocacy groups, practicing oncologists. This is one of those trials when Monday after ASCO, you can apply the results. And for me, the take home here is that all rectal cancer tumors do not necessarily need to be managed the same. If you have a mid to high rectal tumor, which we start with chemotherapy and they have a good response, I think it's worth a conversation with the patient on whether they can forego radiation for that group of patients.
Thanks for going over that, but it's amazing to see how fast this field is evolving. Rohit, you started off by TNT, the short course or the long course of radiation. So when we're looking at this data, it's also important to keep that in mind. And I don't want our community oncologists to walk away or our patients to walk away with this broad blanket that no one needs radiation. A selected few, to what Dr. Beg you've mentioned, perhaps can omit radiation here.
I think for me, this trial gives us a reason to pause when someone has started on the treatment for neoadjuvant therapy, and not to just set someone on a specific path and not reevaluate until they're 6-9 months into their treatment. And if we see that there are certain aspects of the tumor location and the response that we consider whether someone should have chemoradiation or not. So yes, the standard of care treatment option, especially in terms of the delivery of radiation, has evolved, but I think it's made it even more clear that rectal cancer is one of those diseases where you really need to have your radiation oncologist, medical oncologist, and surgeon on the same page and having these discussions throughout the course of someone's treatment.
I think it just adds to the multidisciplinary approach that we need for this tumor or other tumors as well. And it is important to stress how quality of life is taking a front seat in addition to the survival data. We've seen that with MSI high tumors itself, where it has responded so well to immunotherapy, where other modalities have been avoided. And same thing here, where one could avoid radiation to avoid short and long-term side effects.
Absolutely. Dr. Baid, thank you for covering that. Now let's switch gears and focus on pancreatic cancer. Across multiple disease sites, we've seen significant role and success with peri-op or neoadjuvant systemic treatment. We're seeing this with lung cancer. We've also adopted this in our clinic, of course, for breast cancer. However, NORPACT-1, a small study, but this was a negative study in neoadjuvant settings for pancreatic cancer. Dr. Baid, can you walk us through this study design?
We're finally seeing those trials that started 5-7 years ago to start reporting when it comes to the PREOPANC trial. And now here we have the results of the NORPACT trial, where they wanted to determine if delivering neoadjuvant therapy upfront leads to better oncologic outcomes or not. So they took people with upfront surgery and gave them adjuvant FOLFIRINOX, which is the standard optimal adjuvant chemo regimen that we give nowadays. And the other group of patients received neoadjuvant FOLFIRINOX for 4 cycles, followed by surgery, and the rest of the chemotherapy post-operatively. So it's a very well designed study, a very clear study, upfront chemo or not. And when we look at the results here and we look at the Kaplan-Meier curves for the upfront surgery group in blue and the neoadjuvant chemo group in red, we see that the surgery group seems to be doing better than the group that received neoadjuvant therapy. And this caused a lot of people to pause and say, like, hey, should everyone really be getting preoperative therapy? But when we really take a deeper look into the results, first of all, the study only enrolled people with pancreatic head tumor in the head of the pancreas. And if you notice on the study design, the people who were going for surgery up front may not have required tissue diagnosis prior to surgery or biliary drainage prior to surgery, while the folks who were going to get chemotherapy did require optimization of their biliary drain and cytologic diagnosis, which leads to, as you know, a couple of weeks, sometimes delay before initiating therapy. And when you look at the drop-offs that happen at different levels, from the people consented to the people enrolled to the folks who received the chemotherapy, there's quite a bit of drop-off. And you can decide if you do intent to treat analysis and what does that really mean, and what the protocol analysis really means. Those two groups of patients didn't really have the same starting position when I think about it. And some of the FOLFIRINOX people actually ended up getting gemcitabine-based regimen. How much did that impact their treatment? Why did they not get FOLFIRINOX? Was there still some unresolved biliary obstruction maybe that was preventing them from having irinotecan-based therapy, which is why they ended up gemcitabine, that ended up causing sort of impact on outcomes? We're not entirely clear, but we're definitely not seeing the neoadjuvant arm kicking it out of the park and being a clear winner. So for me, it reminds us that we need well-designed trials to address these questions. Thankfully, we have studies such as the Alliance trial and the PREOPANC-3 trial, which are going to give more data with more contemporary chemo regimens, and in different health systems internationally, which can help guide our treatment. But the core problem in the pancreatic space is the fact that we don't have effective treatment options. How many ways can we slice and dice the same couple of chemo regimens and see how it's going to work? We need more treatments, we need new treatments. And until we start seeing more effective treatments coming out in later stage disease and see them move into early stage disease, we're really looking at small impact and sometimes conflicting results from different trials.
Thank you for covering this. And rather, you said it very perfectly that there are some nuances to this trial, but again, this is a very unmet need in this arena of adenocarcinoma. Now, we know that how we saw overall survival being inferior, though this was more easily interpretable in resectable disease. However, when we are in our multidisciplinary room where we are labeling patients as borderline resectable, we tend to utilize neoadjuvant chemotherapy at all times. Do you think this would change the paradigm where we will be shifting some of our surgeons to go for surgery, even if it's borderline, and then consider adjuvant?
Borderline patients were not enrolled on this study. We know from multiple studies that folks that have a borderline resectable cancer, based on NCCN definitions of borderline disease, end up having R1 resections or worse. And that is an independent predictor of a poor survival. So for the borderline group, we really need R0 resections. One could argue that a lot of the resectable tumors or tail tumors would have had R0 resections anyway, and are we really benefiting them? But when I think about the magnitude of impact that neoadjuvant therapy can have, it's in the borderline resectable group that we can have the biggest impact. For folks that are more advanced, well, we may not be able to convert them to resection. So the delta improvement that we can give for that group of patients is not going to be that great. Right. Similarly, in the resectable group, maybe the delta isn't that great, but the borderline, from my understanding of the biology and the data, is actually where we can have the most impact with the neoadjuvant approach. So for folks that have some arterial involvement in their tumor, I would strongly recommend neoadjuvant therapy in that group of patients.
Certainly. As you're talking about pancreatic cancer, and this being devastating disease, our next study focuses on this, particularly in metastatic settings, NAPOLI 3. Previously, we had covered the study post-GI ASCO 2023, but now we have updated overall survival data. Dr. Beg, if you can please dig a little deeper into the study design and its findings following that.
Yeah, the NAPOLI 3 trial looked at nanoliposomal irinotecan-based FOLFIRINOX and compared that with gemcitabine nab-paclitaxel. And it's the first time that these two regimens have been compared head-to-head for a newly diagnosed group of pancreatic cancer patients. They took people who had confirmed pancreatic cancer, newly diagnosed metastatic disease with good performance status, and randomized them to one of these two regimens. For those who are not familiar, this is a modified FOLFIRINOX regimen where the irinotecan has been replaced with nanoliposomal irinotecan at 50 milligrams per meter squared, and the 5-FU-leucovorin oxaliplatin is fairly similar to what we're used to seeing, with the oxaliplatin being 60 mg per meter squared given every 2 weeks. And the gem nab-paclitaxel is the way we've been giving it for years, with day 1, 8, and 15. And they randomized patients head-to-head. And when you look at the Kaplan-Meier curves, the orange Kaplan-Meier curve, which was the FOLFOX, had a higher median overall survival compared to gem nab-paclitaxel at 11.1 months compared to 9.2 months. We had seen early results in GI ASCO. It made a plenary presentation at GI ASCO, and it's good to see that this survival benefit has maintained itself at the 18-month mark, where the difference in overall survival at 18 months is 19 months versus 29 months. So I think we have a winner in terms of selecting 5-FU versus gemcitabine-based regimens for pancreatic cancer. And for people who are about to start their treatment with who have been diagnosed with metastatic pancreas cancer, I think the discussion is much simpler now that we have the results of these studies. Previously, I would at least present both options and make the decisions largely based on whether someone is able to carry a pump and whether they can come in on day 8 and what their risk of neutropenia is. But now we have clear oncologic data that one is oncologically superior to the other.
Dr. Baig, in this particular study, I think a fair criticism was Abraxane a fair comparator arm? Because ideally we would have liked to see modified FOLFIRINOX, because now we're stuck with just cross-trial comparison saying FOLFOX is very similar to modified FOLFIRINOX, and if this is approved, which one do you use?
Yeah, this study didn't try to answer that question. We had the same question when nab-paclitaxel's clinical trials came out, is that nobody compared it with regular taxane, and why are we jumping straight to nab-paclitaxel? So I think we can only interpret these results based on the question that they set out to answer, which was to compare it with standard of care FDA-approved nab-paclitaxel, which before this study started, most people would have said that these regimens are equivalent. So it was a very fair comparator to be evaluated with. But if the question was going to be whether nanoliposomal irinotecan is better than regular irinotecan, that's not what the study was trying to address, for better or for worse.
Absolutely.
And we're kind of stuck with those results.
Now, we do know that nanoliposomal irinotecan does perform at later lines. Now, when in comparison to the first line, if we utilize that, would you keep the nab-paclitaxel or gemcitabine approach single agent in the later lines then?
Yeah, you're right. That's a very important point. Nanoliposomal irinotecan now has activity both in the first line as part of FOLFOX and in the second line in combination with 5-FU. We don't have good second-line data of nab-paclitaxel after progression on 5-FU based regimen. That is what folks are doing in clinic. It is very hard to give gemcitabine nab-paclitaxel 3 weeks in a row in general, let alone as a second line in pancreatic cancer. So folks are frequently modifying that both in the first and second line regimen. But given there aren't many other comparator treatment options, and we know that this regimen has activity in pancreatic cancer, I think it's a very reasonable second line options for people after they've progressed on 5-FU based chemotherapy.
Thank you, Dr. Baig. Now let us jump to a different disease site for our last study, imbrave 050. We know that atezolizumab and bevacizumab was approved in metastatic HCC. This study is looking at the same combination in adjuvant settings. Dr. Baig, your thoughts here?
Yeah, liver cancer and biliary cancers have probably been some of the most exciting areas to be working in within the GI cancer space over the last 5 years. We've seen the emergence of first single agent immune therapy and then combination of VEGF and immune therapy, or immune therapy combinations in the advanced HCC space. But to date, adjuvant treatments in liver cancer adjuvant therapy after surgery or ablation in liver cancer have not yielded positive clinical trials until now. This trial took people who had surgery or ablation with Child-Pugh-A liver disease and randomized them to receiving active surveillance, which is very appropriate acceptable regimen for this group of patients prior to this trial, and compared it with atezolizumab bevacizumab, which is a combination that is approved for the treatment of advanced hepatocellular carcinoma. And they followed folks until recurrence or unacceptable toxicity. And they did allow for crossover, so folks that were on surveillance could receive this treatment subsequently, which we know they would have gotten as part of standard of care, but it's good to have worked that into the regimen as well, because this trial was enrolling before the FDA approval of that combination. And there's a fairly clear separation of curves between the treatment versus surveillance arms, with the atezolizumab bevacizumab arm in blue showing a 12-month recurrence-free survival of 78% versus 70% for the group that was on active surveillance. How can we use biomarkers to help select people in a more rational manner to receive this combination treatment? Who are the folks that are going to benefit? Who are the folks that are not going to benefit? We don't have those answers. But as a group, for Child-Pugh-A patients, who have received curative resection or ablation for their liver treatments, we have very clear indication that a combination of atezolizumab and bevacizumab can delay recurrences. And for this group of patients that are often suffering from cirrhosis, this regimen can be a game changer. I think we need to be aware of immune side effects. We need to be aware of vascular side effects that this regimen can cause. But for a Child-Pugh A group of patients who were fit for surgery, I don't expect there to be too many challenges in the adoption of this regimen for this group of patients.
Certainly, especially with an unmet need when these patients recur after surgery itself. Now, we have RFS, which is pretty promising, but would you suggest before we utilize this in our day-to-day practice to rely on until OS is presented, or this is ready for prime time?
The HCC population can be a little tricky when it comes to overall survival. There is a fairly high rate of non-oncologic mortality in this group of patients as well, because even though they have Child-Pugh A disease, they do have cirrhosis. By definition, most of them will have cirrhosis if they develop HCC. And once you start looking at survival that are extending beyond 1 or 2 years, and we're seeing the impact of surgery and other systemic therapies, we can see hepatic dysfunction creep in and be a major cause of morbidity and mortality in a group of patients. So once the overall survival results come out, I think one of the interesting aspects is going to be whether we can tease out cancer-specific mortality versus not. So for almost any other adjuvant population, your question was easy. Yes, we need to wait for the overall survival results. For this group of patients, there are lots of caveats with the overall survival data as well. So I'm really excited with the recurrence-free survival as being a surrogate endpoint for where we are in the adjuvant space. And I'm excited to see what the regulatory agencies and guideline agencies, how they perceive these results.
We have covered a lot of data here today, Dr. Beg. Thank you so much for joining us and going over these important studies from GI space from ASCO 2023. For our listeners, stay connected for a quick recap. We just got done with our interview with Dr. Beg, covering important studies from GI space from ASCO 2023. Are these all practice changing is the question.
Rohit, our focus has been on practice changing or critically practice informing studies. But I must say, besides Prospect, all the other 3 studies are important, and we might even see the approval for atezo and bev in adjuvant settings for HCC, or for a liposomal irinotecan in pancreatic cancer in first line. But unfortunately, I do not think either of this is moving the needle in a significant way. We really, really need to do better for our patients with these malignancies.
I agree. It'll be important to see the overall survival data for imbrave, but how Dr. Beg mentioned that we might have to rely on RFS or PFS in such complicated pathologies. Furthermore, we saw norpact 1, which was in fact a negative study. We did not discuss with Dr. Beg, but negative studies do teach us a lot and can be practice informing, as we've seen the case with Keynote 789 in lung cancer, as well as Contact 03 in renal cell cancer. And also we saw Attraction 5, which was in fact a negative study where adding nivolumab for gastric cancer in adjuvant settings did not improve recurrence-free survival. We appreciate you joining us. Stay tuned for more clinical relevant studies with us, the Oncology Brothers.